Read. So two papers were from Indian authors. One is from Ashish Ranade from Pune, and the other one was from Dr. Milind Chaudhary from Akola. And we invited them. So these authors will read their paper, and that will give us a nice idea about their journey through this paper. So I'll ask Shalin, please. Dhiren bhai is here. Let's start first paper, which is on cerebral palsy.
Morning, everyone. The first paper for the day. It's from September-October edition of the JPO. Functional and clinical outcomes of combined simultaneous bilateral anterior distal femoral plate hemiepiphysiodesis and hamstring release in management of knee flexion contracture in children with neuromuscular disorders. So, children with neurological disorders develop spastic contracture and thereafter as a sequel a knee FFT. And as has been mentioned previously, that flexion contracture of the knee is the most inefficient type of gait, and it needs to be addressed. This is a recent article written by Benjamin Joseph in the same volume of the journal, which mentions one of the original painting which described the flex knee. So they have mentioned that initial treatment for a flex knee would be stretching, bracing, casting, and a Botox injection. And when none of these work, we would go on and operate with either medial hamstring release, medial lateral release, posterior capsular release. And anterior hemiepiphysiodesis has been a recent option, and supracondylar extension osteotomy when the knee flexion contracture is more, and in adolescents. So the aim when the author started this study was to evaluate midterm results, functional and clinical outcomes for this combined intervention as a single event in the pediatric neurological problems population. They have carried out this study over a period of 7 years from January 2012 to October 2019. They included neuromuscular disorder children, which were operated for bilateral cases with temporary hemiepiphysiodesis of the knee, along with soft tissue procedures with at least an FFD of 10 degrees and 2 years of growth remaining, and no previous surgical treatment were done in these children. They excluded patients with inadequate records who had a previous procedure and who were operated with hemiepiphysiodesis but with different implants, either staples or screws. They included only 8 plates used for growth modulation. In most cases, they did a medial hamstring release. However, when required, a lateral release was also performed. Primary correction on table of not more than 30 to 40 degrees was done in order to avoid neural injuries. And full weight bearing with gaiters was started immediately post-operatively. A photo of the gaiter as shown here was used. And for initial 6 weeks, this gaiter was used for mobilization. And after that, it was removed. 2 week, 6 week, 3 month, and 6 monthly follow-up was done. They assessed the outcome in 2 different measurements. One was functional, because they included mainly GMFCS 3 and 4 patients. They used ability to use a standing frame, ability to put gaiter, sacral setting, and able to place foot on the wheelchair as functional outcomes. And for clinical outcome, they measured pre and post-operative fixed flexion deformity, the popliteal angle, and the time and rate of correction of the FFD till skeletal maturity as the clinical outcome measurements. So in the results, there were 19 cases in all 38 knees. 15 were male, 4 were female, 7 were GMFCS3 and 12 were GMFCS4. Mainly, they included cases of cerebral palsy in the study. However, there were 1 case of hereditary spastic paraparesis, 1 case of Cornelia de Lange syndrome, and 1 case, was a fructose deficiency induced neuromuscular problem. Average age in this case was 12 years with a standard deviation of 2 years, and average length of follow-up was 3.8 years with range from 1.5 years to 7 years. So the outcome, they attained the functional outcome target in nearly 95% of all the patients. The functional outcome mentioned previously was attained. In clinical outcome, when measuring fixed flexion deformity, preoperative fixed flexion deformity ranged from 10 degrees to 60 degrees with an average of around 29 degrees. And in the early post-operative period, they could achieve a correction of up to 13.4 degrees average with a range from 10 to 40. Similarly, popliteal angle initial preoperative was 81 degrees, which would in the early post-operative period would be corrected up to 44 degrees. In late post-operative, the average reduced to 51 degrees. However, they have mentioned the differential in the cerebral palsy cases and the non-cerebral palsy cases. Correction at a rate of average 0.9 degrees per month was achieved, and reflecting a statistically, they got a significant improvement in the fixed flexion deformity with an average of 15.5 degrees of correction within a 4-year follow-up. So they also differentiated the cerebral palsy cases with other cases, and they found a significant difference in the late popliteal angle change, where the cerebral palsy cases improved after initial early popliteal angle change also, whereas the other cases had a slight reduction in the improvement in the late follow. Otherwise, there was no significant difference between the two groups. The average fixed flexion deformity correction range from 15 to 16 degrees. Popliteal angle correction also range from 35 to 45 degrees. And time to correction up to full extension or up to skeletal maturity was around 19 months to 16 months, both the groups. So they have compared their results with recently published articles. So they have found only one study which has used both of this combination, the growth plate hemiepiphysiodesis using 8 plate along with hamstring release. It's a study by Long et al. And however, they've used it as a case control type of study where there you compared the outcomes of only hamstring release with guided growth. The average correction is similar to that study. The average correction in this study was 15.5 degrees. In Long study, it was 15.8. Nazareth had in their study have compared the outcome of only 8 plate versus only screw hemiepiphysiodesis, and they achieved an average correction of 12 degrees. And Al-Aboudi had an average correction of 10 degrees. They have mentioned that the average per month correction rate is the highest from the comparative study which they have obtained in this study, which is about 1 degree per month. However, in their discussion, they have not mentioned the Stevens study, which is considered the standard study for 8 plate epiphysiodesis. The average correction is similar to that study, which is 15.2 degrees. And the per month correction rate in the Stevens study is 1.4 degrees per month. However, they have not compared this to this study. So the limitations of the study would be the amount of correction achieved initially by the hamstring release has been disregarded. They have mentioned the correction of fixed flexion deformity in the early post-operative period. However, the rate of correction, which is 1 degree per month, and the total correction, which is around 15.5 degree average, they have mentioned in one place they have mentioned that it is the initial early post-operative period correction, which does not include the correction which might have been achieved by the hamstring release. So this might be the reason for the higher rate of correction. Many of the patients have not been followed up to skeletal maturity. The average age in this study was 12 years with an average follow-up of 4 years. So many of these patients have not been followed up to skeletal maturity. So there might be relapses if the patients are followed up for a longer period. And even in the early period and the late period, there has been still remaining FFD of around 13 degrees. So even after this surgery of hamstring release and growth modulation, complete correction of the fixed flexion deformity has not been achieved, which would still would not improve the energy expenditure, which would be the primary aim of this surgery. So that's all. Thank you.
Yeah.
Yeah,
So
Shalin, can we go one slide back? We just like to discuss this slide. Yeah, can you make the next slide full screen? The next one. Right. So basically, what you said about this early post-operative period is when you do a hamstring release, you get a quick correction, right? So the surgeon, when they decide to go for the 8-plate, they would go for the hamstring release first. And after that, if there is a substantial fixed flexion deformity, then only they will go for the 8-plate. So what is this early post-operative correction? It is on the 7th day, 10th day, 3 months.
So they have defined early post-operative period as up to 6 months. They have, in the table form, they have included this correction of around 15.5 degrees in the early post-operative column. However, in the literature, they have mentioned that the total fixed flexion deformity, the 15.5 degree difference between these two, has been achieved on a period of 4 years of average and not in the just the early post-operative period. So in the paper, that is one confusing part.
And then the second question, which I could not find out the answer, why they have kept this late post-operative phase empty.
One reason might be that they have mentioned in the paper that the the end point of the study was either full correction or up to skeletal maturity. So if considered as an end point, then there would be no FFD at that point. So,
but like, see, if there is no FFD, then you need to mention that it's a 0 degree and the range is also 0 to 0. Yes. But by making a dash, you are conveying that you are not sure what was the result at that particular of time. Okay, then one thing, if you have carefully read the introduction part, they have mentioned something about hamstring release. See, what are the concern about the hamstring release in cerebral palsy? Why we are not very aggressive to promote hamstring surgery in cerebral palsy? What is the reason for that?
Too much of hamstring means the concept has now evolved to just a medial hamstring release, and we try to avoid lateral hamstring release as far as possible.
Yeah, but still now the concept is going further beyond, and they say that don't go for, yes, Chinmay has already answered that very well. That's exactly. So when you carry out hamstring lengthening, even the medial hamstring lengthening has a tendency to cause anterior pelvic tilt. And if you have heard Paulo Selber at any point, like say he's very much against doing anything to the semimembranosus, because he says that as soon as you do lengthening of semimembranosus, it leads to anterior pelvic tilt. In the introduction of this paper, they have mentioned about this, that it leads to anterior pelvic tilt. But in the subsequent part of the paper, in their study, they have not considered that point at all. So that's one thing, negative part of this, because you do only 8-plate, and if you do 8-plate plus hamstring release, then I would be interested to know what is the effect on pelvis, which is where I am really, because that's a side effect of hamstring lengthening. So I would suggest you to write to the author that why you have not taken that into consideration. They can always say that we don't have a gate laboratory and because of that we have not considered, but try to explore this and also ask the question about this late post-operative phase.
Yeah. So I just differ here a bit. So this paper is different. It is not about ambulatory children with CP. If you see,
it's a 3 and 4. It's a 3 and 4 both.
So you cannot do gait analysis in 3 and 4. That is, and those have been severe 3, 4, and 5. You know, these are the patients here. So in these patients, if you do a hamstring lengthening and pelvis tilts anteriorly, it is an advantage. The problem is if the pelvis is tilted posteriorly, there is a sacral sitting. The entire weight comes on the sacrum and not ischial prosthesis. And that is what gives rise to pressure shows in these patients. So non-ambulatory children with CP, those who have knee flexion deformity, the whole aim of correcting these children is not to make them to walk better. They are only for transfers and to allow them to sit better. So if the aim is to allow them to sit better, the hamstring lengthening would be part of the strategy. So in an ambulatory child, to keep the pelvis neutral in erect position, and a non-ambulatory child to allow them sitting, the hamstring lengthening strategies would be different. However, I agree with you in this paper, most of the correction has been obtained through hamstring lengthening and not by effect of growth modulation, as we can see very well from early post-op results. The late post-op result, what I feel is that they may not have measured the knee flexion deformity, and that's why they have not written, which is a shortcoming of this paper. And the reviewer should have actually pointed this out before publishing it.
Yeah, so
those were my points. Thanks.
So what I thought that late post-operative, their average follow-up has been 4 years. So over 4 years, this deformities would have gradually improved to 0, but they should have mentioned that. Now, what are the complications of 8-plate, Shalin? They have mentioned, anterior 8-plate, implant failure or knee pain.
They have not mentioned implant failure. They have just mentioned 2 cases of knee pain, and one of them resolved with spontaneously and one with an 8-plate removal. They have compared it with previous studies where there was impingement, there was back out of the screws, but none of those complications have occurred in this study.
So I was Dhiren worried that once, if you do not have complete correction of the deformity, even at 6 months after surgery, then the quadriceps strength would never develop, But as Taral said, that these are kind of almost non-ambulatory children. The quadriceps strength, probably it's not their perspective in this paper. Is that the reason? Otherwise, if in early post, that is 6 months post-surgery, if they have 13 degrees of knee FFT existing, then there will be a ongoing patellar tendon elongation while the child is in stance, and this crouch will not disappear,
So exactly, that's what the question is like. If you look at the range of deformity, it's 10 degree to 60 degrees. So at 60 degree, we expect that there is definitely quadricep lengthening, some element of quadricep lengthening. Now, see, only few of the patients are GMFCS 4. There is, I think, at least 10 patients. What is the exact number, Shalin, of GMFCS 3? You showed it well. Yeah. So yeah, GMFCS 3 are 7 patients. So these 7 patients, we consider them ambulatory. And definitely, like, we have more patients, and we don't know, we can't carry out GMFCS for the rest of the condition because it's not cerebral palsy. So again, I doubt, like, say 7 plus 12. GMFCS is only for cerebral palsy, not for the other condition.
Yeah.
So again, if I would be a reviewer, I would point it out that you should not use GMFCS for other 3 conditions.
Another thing, Shalin, which you mentioned, the popliteal angle increased in other 3, like HSP and other condition, is probably the weakness of the anti-gravity muscles, which would persist. While in CP, with the therapy or strengthening, the quad strength might have increased. And that's why the popliteal angle, late popliteal angle, is higher in the other group. Fine. So overall,
if you notice that there is minus 20 popliteal angle, which means many of them are into recurvatum actually. And in the 60 degree, flexion deformity has corrected only to 40, which is the failure of a procedure.
Yeah.
If you're operating a child for 60 degree flexion deformity, and he ultimately lands with a 40 degree flexion deformity, so it's not work.
So Taral and Dhiren, in your practice, when you use anterior 8-plate in cerebral palsy kids?
Okay, a very good question. And my current strategy is when you go for the semi-T release, and if you are not able to correct the deformity fully well, child is less than 12. So fully well, I mean that there is a FFD of around 20 degree persisting even after semi-T transfer. and child is like 2 years of growth is remaining, in that case only I would consider for anterior guided growth.
So one more thing which we
Taral,
get from all these papers, no, Maulin, is that correction with 8 plate is never more than 15 degrees in best of the series. Which means if you have 30-degree knee flexion deformity remaining, it's not going to be corrected by 8 plate. It will be corrected to 15 degrees only. So as Dhiren bhai mentioned, a flexion deformity remaining of 20 degrees or less is an indication for doing 8 plate after you've done your hamstring procedure and serial plasters.
Now the question is, we see after doing, when we couple patella plication with semi-T transfer, sometimes the post-operative knee flexion is an issue. They take some time to resume their knee flexion. What has been the experience when we couple anterior 8 plate? Does it make the knee flexion painful or a problem? The Indian children, some of them, they like to sit cross-legged on the ground, and then parents are complaining that after patella plication, they are not able to do so. So does that increase the problem of knee flexion, Taral? Or Dhiren bhai, what is
I
your
have not seen, because the correction done by anterior epiphyseal, this is not great. It's just 15 degrees or 20 degrees at the most. And we are not using plates, we use screws. We are using screws for these procedures. So they don't impinge on the extensor mechanism. So the two causes are...
No, I think, Maulin, you are asking a slightly different question. You are asking about like when you add patellar plication, that does not allow the full knee, full flexion of the knee post-op. That is what the question is. So my understanding of the situation is like, or the experience is like, initially for a year or so, they complain that they are not able to achieve full knee flexion. And naturally, because we have already shortened the quadriceps mechanism purposefully, so they will take some time. And I usually don't like to be very aggressive to gain flexion in the initial phase. But over a period of time, say after 1 year, they get full knee flexion, and then they will be able to do all this cross leg sitting and all that. So none of the patient has complained in a long-term follow-up that we have lost this functional activity of sitting cross-legged. So, but yes, for first year, definitely they complain at every visit.
Fine. Thanks, Shalin, and thanks everyone for your valued inputs. Let's move on to the next paper. Ashish is here, and it's a review paper. So, Ashish, please, can you share your screen?
Yeah, thank you, Milind bhai. I really appreciate the opportunity. Would like to thank my co-authors. So we looked at the primary bacterial biomyositis, and we did a systematic review of this. In a nutshell, as we all know, it's a intramuscular infection. It has two stages: the invasive stage, that is before abscess formation, and the abscess formation stage, and it could be primary or secondary. So here specifically we looked at the primary, which is hematogenous biomyositis in children. So we prospectively registered with the Prospero registry. Librarian helped us with the literature search. So we did literature search dating back January 75 to June 2020. And that was, we included those studies for microbiology and treatment part. And since MRI was not used commonly before 2000, we did not use the diagnostic modalities to do the data interpretation for studies which were done before. I'm sorry, it's a mistake that it should be 2000, not 2020. So 2000 to June 2020 for diagnostic modalities. We wanted to describe the current state of knowledge and describe the demography, the presenting features, the microbiology, imaging, and what treatments were then and what are the complications of primary biomyositis. So initially we identified 156 studies, and then after removing duplicates, 149 studies were removing, and all those records were screened. Of those, we assessed full text article and read those 39 studies. And again, by excluding certain articles, we included 23 in our final analysis. The quality assessment was done using a tool, and basically we used a criteria which has 5 questions. Is the patient representing the whole case? Was the diagnosis correctly made? And that is to grade the degree of evidence. So it's an analysis of a pool data of 361 cases from 23 articles. The average age is about 8.4 years, more common in boys. What was interesting that the mean time from diagnosis, from the onset of symptoms, was about 6 days. And the mean length of hospital stay was about 12 days. The common presenting symptoms were fever in almost about 70%, but interestingly, 30% of kids may present without fever. Painful limb in about 48-49%. Localized pain, again, the same 47%, swelling in 43%. And then the rest, like inability to use the limb, general malaise, abdominal pain. So in general, all these symptoms could be very non-specific or could be pointing to any other musculoskeletal infection in a child. The common sites, so of those 361 cases, the commonest site of involvement was iliopsoas in about 25%. So basically the pelvic muscles, they were involved in about 44%, the obturator, the gluteus, the iliopsoas. Multifocal involvement was present in about 7 or 8% of cases, and quadriceps, gastrocnemius, and all the other muscles were to a smaller degree. The diagnostic modalities which were commonly used and how correctly they diagnose. Unfortunately, there were no studies comparing, say, ultrasound versus MRI or ultrasound versus CT. But in majority of the cases, when MRI was used, 99% of the times it was able to diagnose the biomyositis. When only ultrasound was used, it was diagnostic in 67% and CT scan in 58%. The culture positivity rate, when the aspirate was from the site of biomyositis, it was 70%, and the blood culture positivity rate was 46%. The total count, the CRP, ESR were, as you can see, were around 14,000, around 40, and around, again, 40 in all the cases. The commonest organism, it was the previous studies especially, it was unspecified Staph aureus, about 30% of cases. MRSA in about 5%, and MSSA in about 25%. So Staph aureus was the most common organism, followed by group A streptococci and strep pneumoniae. The treatment part, the medical management. So medical management was successful alone in almost 40% of cases. So 40% they were treated successfully with just medications. The average duration of antibiotics was about 31 days. The mean antibiotic duration was approximately 9 to 10 days. And the mean duration of oral antibiotics was about 3 weeks, 22 days. Almost 40% cases were treated with surgery. And using this analysis, I mean, this is a shortcoming. The predictors of surgery were large values of TLC and ESR, surprisingly not CRP. So the increasing trend in the TLC, the total leukocyte count, and ESR was probably predictive of surgery. And again, painful limb and fever, but that I feel is very non-specific. So surgery was performed in about 40% of cases. Most of the cases, this was an open surgery, incision and drainage. And percutaneous drainage, CT or USG guided, was done in a short number. The complication majority, 90% had favorable outcome, 10% had complications. So this study included cases up to June 2020. Hence, we have not included Maulin Bhai's article, because when that was published, this paper was under review. Osteomyelitis was the commonest. Septicemia, septic arthritis followed the rest, and mortality is extremely uncommon. So in general, it has a very favorable outcome. lot of limitations of this kind of systematic review. We could not do meta-analysis because there are no randomized trials. So it's not possible to comment on meta-analysis. Definitely, there is a need for prospective multi-center studies. There are no studies which report patient-reported outcomes. There are no studies which compare role of ultrasound or MRI, because in country like India, availability of MRI, availability of anesthesia for MRI remains a challenge. So studies are necessary, which will outline this. So in a nutshell, in order to diagnose biomyositis, one need to have high index of suspicion, because if it is diagnosed early, the outcome is favorable even with a short course of IV and oral antibiotics. A vast majority may not need surgery, but remember the presenting symptoms are very vague or very non-specific, and they can point to any other musculoskeletal infection in a child. Thank you.
Yes, it's a nice paper, Ashish, and what I have felt, and we discussed before also, like the typical age of getting joint infection in the country is around 5 to 8 years. But when we see adolescents with muscle abscess, then we should think of this topical pyomyositis, and especially the MRSA is the culprit. And those children are doing, they have a lot of problems, as you mentioned, progressing to the joints, progressing to the deeper muscles, producing these septic thromboembolism and all. Now, my question is, what led you to write this paper or study this?
Yeah, so that's good
I mean,
question.
is it more, what I feel is we should produce such patients and their complications in the form of osteomyelitis to pediatricians, because they tend to treat them as an isolation, and they don't venture into investigating whether underlying bones are involved. So what was the main purpose of this paper?
So a couple of years back, I had successive patients presenting with refusal to walk, USG showing some effusion, but it turning out to be something else like osteomyelitis or pyomyositis. And reading on that, I realized that there are very few studies, or majority of the series, they have patients like 20, and not much literature out there that how do we proceed with this. So we thought this might be a useful exercise to know more about pyomyositis, because I feel we see it more frequently than what has been reported in the literature. I'm sure all of us would agree with.
Yeah. The problem is the tropical countries, the belt of tropical countries starts from South America, then African countries, then India and Southeast Asian countries. And if you see the literature from these countries are relatively less compared to Europe, North America, and Australia. Probably that's the reason why we are not reporting as many as is there.
You know, I was, yeah, sorry.
Yeah, please go ahead.
I was surprised to know that only few cases, like 22 cases in quadriceps have been reported. I think we see it very frequently, you know, on the extremities in the child.
And based on this study, what are the risk factors of pyomyositis which would culminate into osteomyelitis? What factors they have described?
Unfortunately, Maulin, this based on this published literature, it's not possible to deduct any conclusions.
Fine, thank you very much for that detailed.
One last question, maybe you can answer it later on also. What is the process of doing a review article? Did you have to take help of epidemiologist, or the process which you describe, or you could do it on your own, or were you trained for that?
Yeah, I did a course in CNC Vellore on the Cochrane, developing a Cochrane protocol and writing a review. And we did take help of a librarian, and we prospectively registered with the Prospero registry, which is based out of University of York. So there we have to give them methodology And they make sure that there is no other study which is looking at this, because we don't want to duplicate. And then we created the data points and started creating an Excel sheet. The statistician was involved right from the beginning when we started collecting the data.
Excellent. Yeah.
Fine. Thank you very much. And Dr. Milind Chaudhary is with us. Milind, can you share your screen and please read your paper? We are excited to learn from you about it.
Hi, good morning. Can you see me?
Yes, we can.
Good morning. Thank you for your very kind invitation. I beg your indulgence. I'm not very completely well prepared. In fact, my paper is not here on this laptop, but I will be reading it out to you. This is a subject which is rather dear to my heart. I've been performing limb lengthening surgeries for the last 32 years. And the paper is, so I'll first read the abstract while I'm hoping that I will get it on the screen and be able to show you as well. So this is a study of, okay, so let me see, I think I have it here.
So you want me to put the abstract on?
I have it here now. I'm trying to, I'm trying to, see where is the share screen dialog, so that
you click on this Zoom thing, and in the bottom you will find the green upgoing arrow, that is share screen.
I got that. Okay.
And then you can share.
Got that. All right. Okay.
Yeah.
That's
good. Yeah.
Okay. So this is it's a rare anomaly. The abstract says it's characterized by a decreasing deformity and an increasing limb length discrepancy. Now, lengthening in CPMBT has not been described extensively. Our series compares the duration and complications of lengthening in younger versus older children and young adults to determine the safety and benefits of early lengthening. So we studied 28 tibial lengthenings performed by a single surgeon in a dedicated center in 23 patients. And it so happened that they neatly happened to fall into two groups of 14 segments each, where we had less than 5 years and more than 5 years. It so happened that they were preschool and school and onwards. They were all lengthened with circular external fixators, and 3 were lengthened over an intramedullary nail because they presented to us as adults after skeletal maturity. So we measured the preoperative and postoperative sagittal coronal oblique plane deformities, like many other studies have, but we focused also on the limb length discrepancy, the percentage of the limb length discrepancy, the amount of lengthening we performed, the percentage lengthening performed, the external fixation duration, and the index. And we graded complications, I think, according to an important criteria, not just by the Asami bone score or by the Paley's method of classifying complications as problems, obstacles, and complications, but rather by using the Lascomis criteria, which are rather more stringent because it takes into account the duration of the fixation. And it's rather unforgiving. So the results were that we had the group A, the younger children, had significantly greater deformities to start with, okay? And, the mean leg length discrepancy was similar in both the groups, 3.4 versus 4.1, centimeters. The expected LLD at maturity, now this is interesting, was LLDM, what we call, using the multiplier method, because we've been doing this since, before the multiplier method, we used the Mosley's method, and since 2000, we used the multiplier. And we found that we had in the younger children, anticipated leg length discrepancy at maturity ranged from 4.4 to 9.5. And in the older children, it ranged from 2.5 to 9.7 centimeters. The commonly held belief is that it's only 4 to 7 centimeters. And then what we found was that the amount of lengthening was the same in younger and older children, no statistical significance. The percentage lengthening was much more in the younger kids than in the older kids. The external fixation duration and index, as can be imagined, and logically was much lesser in the younger kids. EFD of 116 days, less than 4 months, and EFI was only about a month per centimeter, much lesser in the younger kids than in the older ones, with 200 days, that's close to 7 months in the older kids, and 50 days per centimeter. Now, Lascombe's criteria was fulfilled in 11 out of 14 lengthenings in the 11 out of 14 segments in the younger kids, whereas only 3 out of 14 in the older. But if we were to use the Asami bone score, the results were good to excellent in all. So the Lascombe's criteria is rather, stringent. So that was the abstract. And let me go to a few salient points. I don't know how you do this in the introduction. What we find is that though congenital posteromedial bowing of the tibia was described by Heyman and Herndon, I think in 1949, also called as a kyphoscoliotic tibia, it presents with the valgus recurvatum deformity in the middle third, lower third junction. Now, most people believe that the LLDM discrepancy at maturity is only 4 to 7 centimeters. Hence, when the children present to the pediatric orthopedic surgeon or the orthopedic surgeon, they believe that it can wait for lengthening. Now, less than 30 articles in the English language literature describe this condition, and less than 250 cases. There are very few articles dedicated only to lengthening, and only 4 authors have described lengthening in more than 10 segments. Possibly, ours is the article which has the largest number of lengthenings in this condition, most certainly in the English language literature, though we did not claim so in the article. Less than 90 tibia lengthenings have been described. Most authors describe lengthening nearer to maturity to equalize in a single episode. Now, though clinical and experimental studies have shown the reliability, benefits, and the scientific basis for lengthening in congenital anomalies in younger kids, only 2 studies describe lengthening in young children with CPMBD. Now, one series says that the results are bad and you shouldn't do it. And another small study said, 4 children, the study that said you shouldn't do it was only 6 lengthenings. And the study that said you should do it was only 4 lengthenings. Now, a recent study of 16 lengthenings from the University of Washington, St. Louis, followed up 16 lengthenings to maturity, but they only had 3 young children. And what's interesting is that these people decided to perform early lengthening when they found that the discrepancy at maturity is going to be high. And this series actually from Gordon, University of Washington, St. Louis, found that the limb length discrepancy at maturity predicted could be as high as 16 centimeters. This is a very recent study. And I think it's published in early 2021 or 2020 in the JCO. So we report a large series of lengthenings done by a single surgeon in a specialized center. Now, as I said, the aim was to study the duration and complications in younger versus older children. So, so what we found is that the one thing I would like to highlight is the surgical technique in post-operative care. In the post-operative care, we found that we had to perform more frequent follow-ups in the younger children as compared to the older ones to prevent, complications. We didn't want them to get into premature consolidation of the fibula, which would have made it difficult, the tibia doesn't mature too quickly, the tibia does, and so on and so forth. And, we have to keep them free from pain, and they should be in a position, be free from pain and move around freely with the fixator within a few weeks. The fixator has to become a part of their body image in a really short time. So, here is a figure that shows a 3.5-year-old child who came to us, a precious child born after 16 years of marriage, already presenting with 5.5 centimeters of discrepancy. Now, we also performed lengthenings in many children in the metaphysis versus in the diaphysis at the apex of the deformity. And we studied the differences between the two, and they were not statistically significant. But it makes sense when the young children come to us, as this child did, and the parents had seen, surgeons all over India in the biggest hospitals, and they were told to wait. They were completely distraught because as the article by Niemela says in the JPO of 2007, there is parental suffering and anxiety on seeing their children with the deformities and discrepancies. So actually we didn't use the word suffering, even though it's an article in the JPO, but that's what really is going on. And so we lengthened him through this. As you can see, the fibula wants to mature earlier. This child also had a fibular repeat osteotomy. And what's, since the child is very free, slowly the regenerate matures really well. And, in most instances without bone grafting or without complications. And we also do not resort to a foot frame to prevent equinus because they're freely mobile. So, there's another child who's in the older group who presents to us at 8 years of age, is a large discrepancy, 6 centimeters. So it made sense with a larger tibia to start with. So we performed a double level lengthening at the apex of the deformity as well as in the metaphysis to try and reduce the fixator duration. We also studied the fibular migration from the ankle and from the knee joint. We used the screws to prevent this. And the migrations were minimal and there was no difference in there's definitely more migration in the older children. And here is somebody who presented to us at maturity with CPMBT. You can see the residual bow. So this is what happens. Though the discrepancy increases, it's not noticed. The deformity reduces and hence the kind of pressure for those children and parents who've been told to wait kind of disappears. And what happens to them is even though they may get a precise lengthening or they may get, which is very expensive, or a lengthening over a nail when they're skeletally mature, by the time they're able to fully weight bear as this 26-year-old could, it was 76 days per centimeter. Even though the fixator comes off and the fixator duration is less, the total healing index, the time to full weight bearing without walking aids, is a dramatic 62 days in this particular patient, going up to 76 in some of the other children. And so here the table which compares the deformity and lengthening parameters. What we found in the older children is that when they come to us, when they've been told to wait until adolescence by most surgeons, is when they get a lengthening, it takes so long that it severely disrupts their schooling and academic activities. So India, unlike the UK and other nationalized health schemes, where the recent articles have come from, which I have discussed in the literature. So for example, right from the Royal National Orthopedic Hospital and the Great Ormond Street Hospital for Children in JCO, published in 2017, 17 lengthenings in CPMBT from these two great institutions. And they recommended waiting till maturity. I suppose that's partly because the national health policies dictate how many lengthenings children can have. And the presumption and belief is that we should wait and try and perform only one lengthening. Even though the logic is correct, it translates into great difficulties for the children. But if you're in the UK and if you're going to get a lengthening and you have a frame on the leg, as they call it, you're going to get your life easy because the social services and your GP is going to write to the schools. The hospital is going to make sure you're going to not get into difficulties. Similarly, Di Gennaro from the Institute of Orthopedico Rizzoli in 2020 presented 22 lengthenings done over, gathered over many years in such a large orthopedic institute. And they also recommended lengthening nearer maturity or adolescence. This is probably because the cost of the fixators to the institute and to the nationalized health scheme is really high. And they dictate that you should perform lengthening only once. So, these are some of the topics we touched upon. We also touched upon the complications. The largest issue that we faced was that the kids could not mobilize well when they were older. They had become, obstinate, a little obese, poor coordination. 2 children developed large valgus deformities after the fixator came out. Definitely their schooling was interfered with. Anecdotally, I have very interesting stories about how easy it is for the younger children to be handled by their parents, to be brought in for treatment, how soon they become free from pain if you are diligent enough, and how much the older children suffer. They become immobile because they can't go to school. The school principals and the administrators do not want to take the responsibility of dealing with a child who's got a fixator on the leg, so on and so forth. And we had equinus requiring soft tissue release in only one child in the older group and none of the kids in the younger group. We have had fibular premature consolidations and fibular non-unions. One interesting complication in a younger child we reported was a 3.5-year-old who had a large deformity and developed a breathing difficulties in the evening of the surgery. The pediatrician prescribed steroids. Either that was the reason, or because it was a really large deformity, his bone did not form well. We had to resort to bone grafting, which is one of the very few lengthenings, not only in the CPMBT that we have performed, but in the entire series of thousands of lengthenings that I have done. Now, we compared, like I said, our series with that of the literature. The series of, mostly people describe deformities. Shah and Doda Basappa and Joseph in 2009 in JPO B described 20 children, but they mostly described the deformities. And they tried to correlate, the coronal plane deformity with the eventual discrepancy. They'd lengthened only one child and no details were forthcoming. Chaudhary in 2009, again, JPO, lengthened 6 children and recommended against early lengthening because of complications. Aryavat from Thailand described 4 children, but mostly the recent articles which have come from Wright in RNOH and Gosh, in 17 children, before that from Sheffield Children's Hospital, Kaufman in 2011 described 11 children. Then, as I said, Di Gennaro in Instituto Ortopedico Rizzoli, only 22. And, so it's a very large series. And what we found is that if you pay due attention to the lengthening process and prevent complications, frequent follow-ups, you can get a good lengthening and you need not get any growth inhibition. We addressed this in the, so this is this shows the Lascombe's criteria and our patient, breakup. We looked carefully at growth inhibition because this is a worry that most pediatric orthopedic surgeons have, that if you perform early lengthening, you can create growth inhibition. And they believe that you can simply perform a, epiphysiodesis nearer to maturity. So let's talk about growth inhibition. So Mike Saleh, long ago described that if you do less lengthening per episode, but if you repeat the lengthenings, you won't have growth inhibition. Sabharwal found no inhibition from single segment lengthening below the age of 6 years. If you perform femur and tibia lengthening, the chances of inhibition is higher. And then finally, Gerno, from the same group as Lascombes, recommended that if you perform lengthening, it should be less than 30%. And the largest lengthening in our series was only 29%. And the second episode of lengthening should be at least 3 years spaced out and do not perform more than 2 lengthenings before skeletal maturity. And all our children have fulfilled this criteria. So we are not worried about, growth inhibition. And this is borne out in our results. We followed up 7 children till maturity. And, so recently Obst in a review in JBJS has turned the logic of doing epiphysiodesis for discrepancies of 2 to 5 centimeters around. And it's made a strong case for lengthening when the discrepancy is going to be more than 2 centimeters, as they have found larger problems when people have more than just 2 centimeters. And epiphysiodesis is not a panacea. Firstly, it reduces the overall height. Secondly, Black from the TSRH has shown that many unexpected things can happen. Not only you may not hit the target of the inhibition that you wish to achieve, but you may develop intra-articular deformities because of the placement of the screws and so on and so forth. So though it's easy to perform, it's certainly not a panacea. But we did have some limitations. I'm coming to the end now. It is a retrospective study. It's a reasonably small sample. Not all the children have been followed to maturity. We have followed up 7 until maturity. Now, estimating leg length discrepancy at maturity using the multiplier method is not as accurate as methods that rely on skeletal age, which require 2 readings, we agree. But that issue crops up when you really want to perform lengthening or estimate the remaining leg length discrepancy at maturity when they present to you nearer to maturity. Earlier on, when the children come earlier, the multiplier method is reasonably accurate. As you go closer to adolescence and nearer maturity, you need to use methods that use skeletal age estimation. And finally, our I think, limitation is that not all surgeons are comfortable advising lengthening at an early age. Not all health policies of governments can agree to this concept. And once the surgeon has enough experience and the parents desire and are worried about the discrepancy, they understand LLDM and they wish themselves, they understand that two small lengthenings are easier for the child to tolerate if the child has a lengthening before reaching school and he's not handicapped, he's able to run around, his growth and development is much better. Correcting the axis and lengthening will stimulate growth further. These are all things in the literature. So, with the right circumstances, it may be not a bad idea to lengthen children early.
Right. Thank you, Milind. That's a great paper and great experience over 30 years. So I'm sure that this paper has taken a lot of toil on you to publish it. Now, I have a couple of questions, and you have partly answered them during. So I read that 5 out of 28 children required a re-lengthening, right? So as you mentioned that 23 children and 28 lengthenings. Does it mean that 5 children required a re-lengthening at some point in time?
It's actually 5 lengthenings, 5 repeat lengthenings. 3 children we did repeat lengthenings, and 2 of these were below the age of 5 years. One of them was from the older group. He presented earlier, and we found that if the child has an early lengthening, a repeat lengthening is not an issue. The time taken, the statistical significance of the external fixation duration index is not much higher. It's easier for the child to tolerate. And
right.
Yeah.
So that's one thing. And so whenever we perform an early lengthening, then we have to also mention to families that the child might need another lengthening in future.
Absolutely. We begin with
yeah.
The counseling begins with explaining to the parents what is leg length discrepancy at maturity. Some parents are easily able to grasp this. All parents grasp this. They understand growth.
Yeah.
And they want to know, what's going to happen. They want to know whether one lengthening is going to solve the problem. And we explain to them that the short limb is growing at, let's say, 95%. And it's going to continue to grow at 95%. It may get a little stimulus and may grow at 96%. And, possibly we may require a second lengthening. We explain, they easily understand the concept and they buy into it. We don't sell the surgery. We don't sell the surgery to them. They buy it. They demand the surgery, usually.
Right. Another thing which I saw in a couple of cases of young lengthenings, through multiplier method, the expected discrepancy at maturity in the range of 9 to 9.5 centimeters, and then you have lengthened 6 centimeters in one, 6.7 in the other. So, so what happens to those children? So, when your lengthening at a younger age is less than multiplier method prediction, so do you need another lengthening in those children? Like, please go a little up. Or what happens to this multiplier, expected? Now, say, for instance, in this child, the expected discrepancy was 9.7 centimeters and you lengthen for 5.5. So what happens to the rest of the expected discrepancy?
Yes.
Or my other question is, once we lengthen them early, does the expected discrepancy reduce, or what is your experience?
Yes, Maulin, that's the interesting fact. So what happens is that these kids at a very young age, so his discrepancy to start with was 4.5, 4.7. And when we lengthened him and we found that he's tolerating the lengthening easily, we over lengthen a little bit, 5.5 we started off with. And what we found in the children to whom we have followed up till maturity, there was a child I operated in the year 2000. He was 2.7 centimeters short. He had a discrepancy of 8.7 centimeters. I lengthened him to 3 centimeters when he was very young, at 1.5 years of age. And then he came back again at the age of 11 years for a second lengthening, where he got 4 centimeters in the metaphysis because the diaphyseal deformity was gone. So I totally lengthened him for 4.1 and 3. So he got 7.1 centimeters of length, but his multiplier method said 8.7. And when we followed him up to maturity, he was only, I think he was only 7 millimeters short, okay, with only 2 lengthenings. So there is a stimulatory effect of early lengthening. And that stimulatory effect, you can have if you don't over lengthen, if you don't lengthen the femur and the tibia, so yeah, it's not, scientific to make a claim like that. I'm not making the claim in the paper. I'm not making the claim in the paper because strictly in the language of science, I would, I would need to see all of these kids at maturity, and I understand that.
So in other words, like this multiplier method is predictor of non-intervened extremities. I mean, how it has been developed from Dr. Pellis' perspective. Are those the discrepancy assessments are for unintervened extremities?
And that's a very interesting question. Now we're really getting into the heart of the matter, Maulin, and I appreciate these really nice questions. So, if you really get into the depth of it, it really gets very interesting. The multiplier method, as the Moseley's method, the chart, and all these methods that estimate discrepancy are basically based on a cohort of, I think, white Anglo-Saxon Protestant children in South Boston, conducted in the late 1950s. So the racial and ethnic measurements that were made as a basis for all methods of estimating discrepancy come from that far back. And yes, this is an estimate that comes from children who've not had a lengthening before. So like the paper of Sabharwal, Saleh, and Journo, they said that you can get inhibition if you lengthen in so many ways. So the method of, when we start out before the lengthening, this is how we measure their estimated discrepancy at maturity. And now for some reason, most pediatric orthopedic surgeons say that, oh, it's going to be only 4 to 7 centimeters short. And Gordon has turned this on its head. We found 9.5 maximum and an average of more than 7. And Gordon found a range of going up to 16 centimeters of discrepancy. And Dror, though he has not published, has also found large estimated leg length discrepancy, much larger than one anticipates. So this is not a benign condition. It's a benign condition when you compare it with the opposite bowing, which is the CPT, which is, it's a classic MS ortho question. It's benign in that sense, and benign because the deformity reduces, but the discrepancy surely goes up. And, you have to address the limb length discrepancy. It really becomes hard for them to tolerate, the lengthening procedure, and it takes much longer when they're at a crucial junction in their lives.
Right.
Education.
So Taral has a question, and there are a few more questions, so I will interrupt you. Yes, Taral, go ahead.
Yeah, Milind, brilliant paper. A lot of clarity, it brings about with the subject and new concepts. So one question I wanted to ask you is, there are extremes of limb length discrepancies in children with congenital posteromedial bowing. As you said, some of the children can have extremes of limb discrepancy, like 9 centimeters or 10 centimeters, and which means at 4 years age, they would be 4 or 5 centimeters short, and you are absolutely justified in lengthening them early. But suppose a child comes to you at 4 years age with 2 centimeter limb length discrepancy, which would result in around 4 centimeter limb length discrepancy at maturity.
Yes.
Would you also correct deformity and lengthen him at 4 years age, or would you rather wait at later on to do just a single lengthening for that child? Okay. So what are your indications for early lengthening? Do you lengthen all the children which present to you with CPT at early age, or you have criteria for selection?
Okay, that's really nice question, Taral. Thank you. There are two issues going on here. One issue is what do I do and what do I recommend and what should be the official line? Definitely. So, okay, so let's start at the beginning. The thumb rule is that for girls, whatever is the discrepancy at the age of 3 years is going to double at maturity. And for boys, what's the discrepancy at 4 is going to double at maturity. So you asked the question about lengthening at 4 years. Now, if it's only 2 centimeters discrepancy at the age of 4 years, it's a mild discrepancy. And I would definitely have a good discussion with the parents and tell them that I'm not going to, sell you limb lengthening, and, you can jolly well wait and decide to get, just give the child a raise, or you could choose to have a 2 centimeter lengthening, because this is me. For the average orthopedic surgeon, for the average, let's say, surgeon who's not performing many limb lengthening surgeries on a routine basis, it's, offering limb lengthening at a young age in a young child need not be easy. It's fraught with complications. So the surgeon should decide. The gist of the article is, if the surgeon has enough experience, and if the parents understand the discrepancy at maturity, and it's a mutual contract, like the LASCOM's triple contract, one of the contracts. It's a mutual contract between the parents and the. So I would not necessarily sell 2 centimeter lengthening at 4 years. That's a short answer to your question. Not necessarily sell it. I could tell them
ability of a surgeon to do a surgery is not an indication for surgery. So selling, you'll have to take a stand, because parents will tell you, we will do whatever you.
I have taken the stand. I told you. I will not necessarily advise lengthening for 2 centimeters at the age of 4 years. But if the child has come at the age of 1.5 years and it's already 2 centimeters or more, I know the discrepancy is going to be much larger. So definitely,
I agree. Yeah, one more question, Milind, was that there are a lot of secondary deformities in posteromedial bowing, which occur at lower end of femur, upper end of tibia, lower end of tibia. Now, do you feel that by doing early deformity correction and lengthening, some of those secondary deformities, can it be prevented? It may be a question to be asked for further research, but by doing early correction, do you prevent secondary deformities which the nature is trying to produce, and make your job easier or lessen the deformities for future?
Really interesting question, Taral. I have seen some, young folks who've come to me at maturity. The Shapiro's index and the Malhotra grading of, the distal tibial epiphyseal, deformities that, that Hitesh Shah described in detail, and a lot of papers describe the deformities. Very truly, these are secondary and almost tertiary in importance. And possibly they don't have, a bearing on the functional ability of children, at maturity. A lot of people have looked into it, and, Dror in the Asami 2014 conference, when, Dr. Chaudhary and me spoke back to back about early versus late lengthening, he said, he was trying to, give the same idea about, this secondary deformities as he does in SHORDT, in fibular hemimelia. He was saying that it's a great idea to shorten at the distal end, get the fibula and the tibia to match up. And I suppose he's done a few of these, but he hasn't published. So I think they are of secondary importance. And the lengthening that we perform early is definitely going to stimulate growth, is definitely going to help the child not be handicapped, run and play better, and cope much better. And if he needs a second lengthening, it's going to be really easier. So that's the, at maturity, I haven't seen these secondary or tertiary deformities posing a great problem. So
yeah,
to answer your question.
So there are two technical questions, Milind. One is, in some children, we see that this congenital, the apex of deformity is pretty low.
Yes.
And then, and the young child, so you have less space in the metaphysis to put your rings and wires in.
Yes.
So how do you deal with that? That's one. And do you do acute deformity correction followed by lengthening, or you put your hinges and do it simultaneously?
Right. So yeah, that's a really interesting question. So we are all aware of the fact that you know, if we correct a large deformity acutely and then lengthen, possibly the length, you know, the potential for lengthening may reduce, and so we only correct it gradually, you know, length and then gradual correction always. And it's quite possible with the help of Elizarov wires and what we call as the pediatric half pins to, you know, even if you have hardly 2 centimeters of a segment, you can still, you know, get a good fixation, really good fixation. And we haven't resorted to a foot frame in young children. And proper tensioning techniques, you know, looking at, you know, the stability of fixation, you know, the regenerate bone itself gives a clue that the fixation is stable or not, and things like that. But you can get good fixation, pediatric half pins, because I don't use, you know, thin wires. I use the 1.8 adult wires in the kids, and I don't use the pediatric frame, you know, so the frame is much stronger than the child. So it's quite stable. There's no worries on that count. If at the end of the surgery, you know, you've had a stable fixation, so less of a worry, but gradual correction of the deformity, surely. Gradual.
So, like Dr. Gaurav Gupta from Delhi is asking, what is the youngest child in your series when you have done the lengthening? I think this case shows it's a 3.5 years old. Do you have anyone younger than this?
Yeah. The youngest I have is 15 months old. The father of this child had seen the best surgeons in India. They'd asked him to wait. And he's a really intelligent man. He said, doctor, this discrepancy is going to increase. I said, yeah. So he said, you know, I said, I'll do the surgery when you're ready for it. He said, can you not do it now? If you do it now, will it not help the child? When he starts walking, is it not going to be good for the child because he's got this large deformity? So I said, yeah, but you know, you may worry. It's a very small child. He said, I'm not worried. If you can do a good job, you know, if you can't do a good job, let's not do it. If you can do a good job, let's do it. So that's how I was. The child did phenomenally well. He just needed one more surgery. He was playing around after, you know, they're miserable for 2 days. You know, all children are after any procedure. But by the 3rd day, if they're free from pain, you know, you've won the race. If they're not free from pain from the 3rd day, you're going to lose this battle. And if you're such a busy pediatric orthopedic surgeon that you can't look after the frame, you should not be lengthening at an early age. That's the cavia emptor. That's the cavia emptor. Even though you've asked the question, I'm not going to recommend this, you know, at all. So you're the best judge about your abilities.
Right. So we have overshooted by 15 minutes. The last suggestion from my side would be, now you have both the cohorts with you, and you should have included a parental satisfaction questionnaire, because we have 2 groups of parents, and I know that we communicate with them. So what is their perception of this early versus late lengthening? Because as you said that we explain and we don't sell. So have you done that?
Yes.
What was the feedback of parents?
Yes, Maulin. We, you know, JPO A has a word limit, and in our limitation,
I know.
it is a word limit. And in our limitation section, we did mention this, and you know, we did want to perform the, you know, quality of life surveys and the parental surveys. Now, this is getting into a realm that, you know, I'm not a specialist in a scientific language, but the feedback that we receive from the parents when we see, you know, how easy it is for them take care of the young children and how difficult it is for the older children. They sit at home and the parents are worried. The child becomes obese, he is less mobile. So yes, I take your suggestion. There is a need for a research article that looks at, you know, these sociological aspects. Much has been written. like the article by Nimela, a lot has been written. But to compare this, it would be a really super specialist psychological scientific literature effort, and it could be interesting. Yeah.
Yeah, because that's only thing which is missing in this paper. Rest is excellent paper. So thank you, Milind, for your time, and thanks everyone for active participation. For those who have not yet left, we please keep 14th of October ready. We have some new science in brachial plexus palsy, and Basim Al Hassan is a shoulder surgeon from Mayo Clinic, Rochester. He is going to be one of the faculties. So save that date, and we'll have some exciting discussion on brachial plexus burst palsy. Thanks, Milind, for your time. Take care.
Thank you very much, Maulin. Thank you for having me. It was a pleasure.
Thank you. Thanks, Ashish and Taral. Bye.
Thank you. Thank you, everyone. Thank you, Maulin.
Ashish, it was a pleasure. I didn't realize. Congratulations on your paper too.
Thank you, sir. Your paper is
Same issue.